Hello, good morning, everybody. Can we have the volume up? Yeah, okay. Thanks for joining us this morning. And good morning. I'm Yao T. This is my friend and dear colleague Supon. We are delighted to have welcome all of you to our very first Asia Pacific Leukemia Consortium Summit meeting in Bangkok. This is really a historic occasion as we gather here to share our knowledge and experience in insights into the diagnosis, treatment, and research of leukemia and blood-related disorders. The journey has been actually quite long for those of you who've been with us from the start. So it's really an effort to a lot of people to really get here. And we are honored today to have with us distinguished delegates from the APAC region, valued industry partners who have actually been very instrumental in influencing the field of oncology through discovery and support. And we are also very grateful to our sponsors and our supporters who have made this occasion possible.
Good morning. On behalf of organizing committee, we would like to extend our warm welcome to all delegates, friends, and colleagues to join this meeting. The first summit meeting will serve lay the foundation for collaboration and encourage innovation. We believe that by working together, we can achieve more than we can alone. We hope that this summit will foster new partnerships, exchange of ideas and best practice, and identification of common challenges and opportunities in the APAC region.
So this program is packed with keynote lectures, exciting workshops, and panel discussions that will cover the latest developments and trends in leukemia and related disorders. And we hope that this renowned panel of experts and local experts from the region will come together to share their perspectives and their understanding to actually advance and participate the field. And we hope that all of you will also participate actively. I know this is the first meeting, and most of us are just still trying to get to know each other. So, but don't be shy. I mean, there's no right, no wrong. So we are among friends here. So contribute actively. Okay.
We are confident that this summit will be a valuable and rewarding experience for all of us. We hope that you will enjoy the scientific content, the cultural diversity and hospitality of Bangkok. Thank you very much for joining us, and we wish you a productive and enjoyable summit.
Okay, as a start, can I again invite our chairs for the first session, Prof. Kwong and Adisak, to come on board?
Good morning. I'd like to thank every one of you for attending this conference on behalf of the organizers. And I also like to thank the organizers for organizing this very marvelous meeting. So to kickstart the meeting, we have a very prestigious speaker here this morning is Professor Selina Luga from the University of Pennsylvania. And she, of course, is currently the professor of hematology at that university, and her research interests are on leukemias, various different forms of leukemia. So without taking up too much of her time, I'd like to ask Professor Luga to come up on the stage to present her talk this morning.
Good morning. Good morning. I want to thank you very much for inviting me to the first summit. I'm very honored to be here. Thank you for inviting me to Bangkok. As mentioned, I'm Selena Luger. I'm from the University of Pennsylvania in Philadelphia, where I have led the leukemia program for a few decades, and I'm currently also the chair of the ECOG Akron Leukemia Committee of Clinical Trials, and I'll be discussing some of our work as I go through this as well. So I was asked to talk about evolving concepts in measurable residual disease and adult ABALL. We'll be talking about some of the advances that have happened over the last few decades. These are my disclosures. So I'm going to start off just by giving a little introduction to acute lymphoblastic leukemia and really what the advances have been over the decades. So most adults will be focusing on adults, although you think of ALL as a disease of children. Most adults with BALL actually achieve a remission after induction and consolidation chemotherapy, often using multi-drug chemotherapy regimens. However, despite the fact that they achieve a remission, the majority of patients will relapse, even after they've achieved a complete remission. And that relapse rate leads to decreased survival, particularly in patients over the age of 50. And as you can see here, survival is much better in younger patients, but significantly worse. And this is much worse than it is in children, where survival is now over 90%. And while significant advances have been made in children, most deaths in ALL happen in adults, even though ALL is a disease of children. And that's because the prognosis of older adults with ALL remains very poor. There are a few different reasons for it. One of them is that there's significant chemotherapy-associated toxicity. Adults do not tolerate the chemotherapy that we're used to giving to younger children or even to younger adults. And we've learned over time that there's an increased frequency of very high-risk genetic subtypes. The more we learn about prognostication in ALL, the more we learn that there are specific genetic subtypes that are of poor prognosis, and those are increased in frequency in the adult population. Now, if we look at the lessons that have been learned in the adult studies, UCAL 12, which was also known as ECOG E2993, was a study that compared chemotherapy with or without allogeneic transplant. It also actually had an autologous transplant arm in the original study. The study showed that actually autologous transplant in that patient population was not of benefit. And so in North America, we no longer do autologous transplant in patients with ALL. But it looked at patients with Ph negative disease and compared them on a donor versus no donor analysis. And what it demonstrated was that those patients who had a donor were less likely to relapse than those patients who did not have a donor, showing a potential benefit for allogeneic transplant in patients with acute lymphoblastic leukemia. However, when you look at mortality, there was not an improvement in survival in the high-risk group. And high risk is considered age over 35 or poor prognostics on the basis of the features that were known at that time, which were high white count and poor risk cytogenetics. So because of a high non-relapse mortality, as you can see here in the high-risk population, the donor population, the non-relapse mortality was 36% at 2 years in those with a donor, but only 13% in those with no donor. So although there was a decreased risk of relapse in this patient population, there was no improvement in mortality because of the risk associated with allogeneic transplant. Now, we made other attempts in the younger patient population, seeing that perhaps allogeneic transplant could be of benefit, but again, in the higher risk, there was no benefit because of mortality. So we looked at studies that had been done in pediatric populations up to the age of 21, and studies that had been done in adult populations starting at age 18. When we compared those studies, for some reason, it seemed that the adults treated by adult physicians did particularly worse than the same adolescent and young adult population treated by pediatricians. And so we asked the question, if we take the adolescent and young adult population and give them a standard pediatric regimen and follow the same rules that the pediatricians follow, can we improve the outcomes in the adolescent and young adult population? So this study was called CLGB 10403. And fortunately, we did show what seemed to be an improvement. By historical control, there was a 34% long-term disease-free, event-free survival. And in this trial, we had a 3-year event-free survival of 60% and a 3-year overall survival of 73%. And we learned a couple more important things, I think, when doing this study. What we learned is that when we looked at MRD at the time of achieving a complete remission, there was a significant difference in 3-year disease-free survival based on whether patients were MRD positive or negative at the end of induction. So as you can see here, those patients who were MRD negative at the end of induction had an 85% 3-year disease-free survival, while those who were MRD positive at the end of induction had only a 54% disease-free survival, so a significant difference. This was also the first study that really established PH-like ALL in the AYA population and its survival. So again, if you look at the patients who were not PH-like, there was a 3-year overall survival of 81% in that patient population compared to 63% in those patients who were PH-like. So these were valuable things that allowed us to then look at additional questions in upcoming studies. A meta-analysis has been done of close to 40 studies. This is pediatric and ALL, looking at measurable residual disease in up to about 14,000 patients with all types of ALL. They looked at various types of MRD analyses, different types of therapies, different methods of MRD for different timing, different levels of cutoff and subtypes. And regardless of what they looked at, and regardless of the therapy or the MRD method or the timing or the cutoff or the subtypes, the results were all the same. Patients without MRD always did better than patients with MRD. And this was for overall survival and for event-free survival. Now, when we talk about measurable residual disease, what are we talking about? And how do we evaluate MRD? There are different ways of measuring MRD. Traditionally, we've always assessed remission by morphology. Morphologic remission only requires about 10 to the minus 2, so 1 in 100 cells are negative for leukemia. We call that a negative remission, a remission without disease. Measurable residual disease looks for much more sensitive assessments of whether or not there's residual leukemia. But again, there are different ways of doing that. So if you do flow cytometry alone, you get a sensitivity of 10 to the negative 4th. If you look at PCR for gene rearrangements or for gene fusions, you get a sensitivity of somewhere between 10 to the negative 4th and 10 to the negative 5th. And if you do next generation sequencing for immunoglobulin and T-cell gene rearrangements, you can get down to a sensitivity of 10 to the minus 6th. So really, the MRD level could become much and much more sensitive, with the number of leukemia cells being much and many fewer if you're using more sensitive methods of MRD. There are some other differences in the methods of MRD assessment. Obviously, you can only do TCR gene rearrangements in T-cell disease. BCR-ABL can only be looked at in pH-positive disease. And the other difference is that if you're looking at PCR or you're looking at next generation sequencing, you need to have a pretreatment sample because you're comparing the MRD sample to the patient's own disease. Well, if you're doing flow cytometry, you have 2 ways of doing it, and one of the ways is difference from normal. So you can do flow cytometry just comparing it to what a normal sample should be. You don't necessarily have to have the patient's own sample to be able to assess for MRD. And the same is true if you're doing PCR for BCR-ABL. You don't have to have the patient's own sample at the time that you're doing it. Now, what does it matter which type of MRD that you do? I'm going to show you an example in pH-positive disease and also show you an example in pH-negative disease. So this is an analysis of adults with pH-positive ALL who are undergoing frontline therapy. There's a retrospective cohort as well as a validation cohort. And they looked at MRD assessment by RT-PCR for BCR-ABL and also by NGS for immunoglobulin. This is NGS MRD in the first 6 months of treatment. You can see here is prognostic for relapse-free survival and overall survival. So these are patients who are MRD negative by NGS. These are patients who are MRD positive by NGS. But there's a discordance. We don't always find that those who are positive by NGS are positive by RT-PCR, or that those who are negative by RT-PCR. So this is looking at the entire group. The majority were concordant. If they were MRD negative by NGS, they were also MRD negative by PCR. And similarly, if they were positive by one, they were positive by the other. But about 1/5 of patients were PCR negative but NGS positive, and a little over 10% of patients were PCR positive and NGS negative. When they compared all of that, what they learned was that what really mattered in terms of outcome was their NGS. These patients were all NGS negative, but these patients were PCR positive, and the red line is the patients who were PCR negative. So RT-PCR for BCR-ABL was not prognostic in patients who achieved NGS MRD negativity. NGS MRD negativity was much more prognostic and led to changes in outcome, even in patients who remained PCR positive for BCR-ABL. So although many of us do continue to follow BCR-ABL and think that that is what we need to be following in this patient population, that's not what is predictive for their outcome. And similarly, you can look at patients with pH negative disease and look at flow MRD as well as high throughput sequencing MRD in this patient population. And similarly, so this is the patient population here that is MRD positive by both flow and high throughput sequencing. This is the patient population that is negative by flow but positive by NGS, and this is the patient population that's positive by both. So there's both a difference in terms of what you look at, and by doing two methods, you get additive prognostic information. So if you can actually do both NGS and flow, you learn more than you do only one, and they're not all identical in terms of giving you a prognosis. Now, there's also a question of when to do MRD and when is the prognostic impact of MRD. So this shows you that MRD positivity at any time is predictive. Again, this is multi-agent chemotherapy similar to 2993 or UCAL12, which is a BFM-like regimen. So these are patients who are MRD positive at week 10 to 16 and or at week 22. So they could be positive at week 10 to 16 and negative at 22, negative at 10 to 16, positive at 22, positive at both. This is their incidence of relapse. If they're negative at both, this is their incidence of relapse. These are patients who, and the duration of CR, again, looking at whether they have MRD at weeks 4 or week 10. If they are MRD negative at both week 4 and week 10, they have an improved duration. But if they're MRD positive at either week 4 or week 10, their CR duration is significantly worse. And this is looking at survival by MRD time point. So this is analysis from the Spanish group, and they're looking at MRD status at day 14 of therapy, day 35 of therapy, and after consolidation. So as you can see, and not surprising, the majority of patients remain MRD positive. 74% of patients are MRD positive on day 14. Very few are MRD negative. If you look at day 35, the majority of patients are MRD negative, but a quarter of them remain MRD positive. And if you look after consolidation, 91% of patients are MRD negative at that time point. So if you look at survival by MRD at day 14, the only ones who really have a fantastic survival are those who are MRD negative at day 14. Even day 14, MRD is predictive for outcome. And if you look at survival at MRD by looking at all 3 time points, if patients who are MRD negative at all 3 time points do even better than those who are MRD negative on day 14. So again, the more information you have, the more prognostic information you can gather. So when should MRD be assessed and how should we use it? Well, if you think about frontline therapy, after induction, it can be used for risk stratification. After early consolidation, We often use it to make a decision about transplant. You can also look at it prior to maintenance to make a decision about how often you should be looking at it afterwards and how therapy should be changed during maintenance. In patients who are going hematopoietic transplant, prior to transplant, it is of prognostic significance. Day 28 to 90 post-transplant is also of prognostic significance. And then the question is, how often should it be checked for ongoing monitoring? What should the frequency be? What should the duration? And how has this been used in practice? The GRAL studies have really asked the question of, can we use MRD to direct decisions about transplant? So historically, if you look back at studies that were done in 2003 and 2005, the indications they had for transplant at that point were a high white count for B lineage, whether or not the patients had CNS disease, whether it had immature CD10 negative disease, T411 or KMT2A rearrangements, low hypodiploidy and near triploidy, or those patients with a complex karyotype. And then you can see if you look at relapse-free survival according to transplant for those patients with higher risk disease, you can see that relapse-free survival was improved in those who had a transplant compared to those who did not have a transplant. And this is looking at MRD at day 8, and you can see that those who do worse are those who do not get a transplant and are MRD positive. So historically, in the use of a large baseline and early response factors to indicate transplant, and transplant was of benefit if they were slow day 8 bone marrow responders, a late CR if they had MRD after induction. Then they go to 2014 and they used MRD to try and determine whether or not patients should get a transplant. So the transplant indications now were no longer white count or such, but they were end of induction MRD greater than or equal to 10 to the minus 3, end of consolidation MRD that was greater than or equal to 10 to the minus 4, or late complete remission. So here you look at their outcomes in 2005 versus 2014. So what's different here is the indications for transplant. So they went from using clinical indications to using MRD and late CR as an indication for transplant. And as you can see that if you use MRD-oriented transplant and just use it in those patients who need the transplant are very high risk, they decrease the likelihood of transplant from 40% to 18%. And disease-free survival did not decrease by decreasing the number of transplants. If you go to overall survival, it seems better in 2014, and that's probably because you're decreasing the number of patients you're putting at risk by transplant. So you're decreasing transplant-related mortality. And so they did a landmark analysis in the very high-risk patients to see, do we still want to do it in those patients? And yes, in the very high-risk patients, there was still a disease-free survival benefit to transplant versus no transplant. And looking at this study, really looking at MRD-oriented allotransplant, we have traditionally thought of KMT2A or MLL rearranged disease as very high risk. But here they looked at MRD in that patient population. And important here is what is called MRD and how did they test it. Not only did they look for absence of the immunoglobulin gene, but they also looked for absence of KMT2A rearrangement. So that was used in terms of calling it MRD negative. When you looked at both of those and you called them negative based on both of those, you had a patient population they did not take to transplant. And just to go through, if you look just at at immunoglobulin gene rearrangement, those who were immunoglobulin gene rearranged, 23% of those patients were still positive by KMT2A. So they were not MRD negative. So this line is the patients who were immunoglobulin negative and KMT2A negative. They did not require a transplant, and their survival is excellent. So even though we think of this disease as disease that requires a transplant, MRD likely supersedes that in terms of determining whether or not a patient is really poor risk. It is probably more likely that those that we consider poor risk are less likely to become MRD negative after induction, and we could use MRD really to define the patient population that needs more aggressive therapy. So what do we do with this information? We've learned that we can take them to transplant, but that doesn't necessarily improve survival because as you do transplant, the higher risk the patient, for some reason it seems the higher the risk of treatment-related mortality. So we can do things like less aggressive, less non-myeloablative transplants, but really what we need is more effective agents that are more effective at treating the leukemia, but less toxic. And fortunately, we have some new agents that have really been approved in the last several years that have really changed the landscape of therapy for ALL. We really used to think of ALL as a treatment where we gave all of our drugs up front, and then we had nothing left to offer these patients afterwards. And these new agents have really changed that for us. So the ones I'm going to focus on a few of them, but these are really targeted agents that really focus on targeting what we have in the ALL cells. The first one really was adding rituximab to patients who are CD20 positive, showed an improvement in survival and has become standard of care in our treatment of patients with acute lymphoblastic leukemia who are CD20 positive. The novel therapies I'm going to talk about, the first one that was approved for patients with relapsed and refractory disease is blinatumomab. Blinatumomab is made up of the variable domains of two monoclonal antibodies. There's a monoclonal antibody for CD3 that's linked to a monoclonal antibody for CD19. And blinatumomab engages CD19 positive cells, the T cells, CD3, and brings them to the CD19 positive B-ALL cells. So basically, think of the CD3 cells attack the CD19 positive cells. The T cells are activated and expand, and they engage tumor-associated antigen, they release perforin and granzymes, and they kill off the CD19 positive ALL cells. The pivotal study that was shown that there was a benefit to this was called the Tower study. It was done in relapsed and refractory ALL. Patients with relapse disease were randomized either to get blinatumomab or standard of care chemotherapy. And as you can see here, there was a survival benefit in those patients who got blinatumomab compared to those who got standard of care chemotherapy. And that was true whether it was in first or later salvage, but the benefit was better in first salvage than it was later on. There was some cytokine release syndrome, and it seemed to be related to the burden of disease at the time of treatment. So patients had more toxicity if they had a higher burden of disease, and the drug was less effective as single agent if they had a very high burden of disease. You needed to give steroids. Now we'll do something like give some Cytoxan to improve the likelihood of the disease of the blinatumomab working in relapsed disease. The other agent that was recently approved for relapse and refractory disease is inotuzumab. Inotuzumab is targeted against CD22. But unlike blinatumomab, it also has a chemotherapy agent that's attached to it, collegiamycin. So it brings collegiamycin to the cells that are CD22 positive, and it retains activity against tumor cells even that have a slow cycling time. The INNOVATE trial was a phase 3 trial that randomized patients with relapse and refractory CD22 positive disease, getting salvage 1 or 2, and it looked for duration of remission as a stratification. Patients got several cycles of inotuzumab, and again, it was compared to standard of care chemotherapy. And as you can see here, the CR rate was 81% in those who got inotuzumab compared to 30% in those who got standard of care chemotherapy, and that led to an improvement of survival as well. Now that was for relapse disease. Blinatumomab has now done additional studies looking that there's a role not just in relapse disease, but even in patients who are MRD positive. Now, these are not randomized trials, but this is the trial, this was the BLAST trial, and this took patients who were MRD positive at the end of induction therapy and added blinatumomab if they were MRD positive. You can look here, and these are the patients who got blinatumomab, and these are the patients who did not. Sorry, these patients all got blinatumomab. These are the patients who achieved an MRD response after blinatumomab, and these are patients who did not achieve an MRD response after blinatumomab. And what you can see is there is an improvement in survival in those patients who achieved an MRD response after getting blinatumomab. These patients went on to allotransplant after clearance of MRD with blinatumomab. And you can see again, those who had a complete response had improved survival compared to those who did not have a complete response after blinatumomab. And then the question really is, if you've had a complete response after blinatumomab, is there really a benefit to getting transplant? Not necessarily. As you can see, those who are MRD negative at the time of transplant, it seems that they did just as well whether they did or did not have a transplant. The Graal study, which is the French group, in their study that I presented earlier, they had a cohort to whom they gave blinatumomab together with consolidation chemotherapy. Blinatumomab was given to high-risk patients from week 12 on as part of their chemotherapy backbone. They got 5 cycles, each one of those for 4 weeks. Or to those patients who were eligible for transplant and were very high risk, they gave it continuously as a bridge to transplant. Here you can see what happened with MRD after they got the blinatumomab. There was a significant decrease, 72% became undetectable by MRD3, so 10 to the minus 3. 56%, 10 to the negative 4. And what you can see here is that the group that got blinatumomab were less likely to relapse compared to controls, and their disease-free survival was improved compared to controls. And also of interest here, that seemed to be most significant in the patient population that were MRD negative, so high risk and destined to go to transplant, but were MRD negative at 10 to the negative 4 before getting their blinatumomab. So the benefit of blinatumomab during consolidation was greatest in those patients who had a good MRD response before blinatumomab. So this observational analysis showed that among patients with high-risk B-cell precursor ALL treated in the Graal 2014 trial, the addition of blinatumomab during consolidation resulted in a higher MRD response rate, extended disease-free survival, and reduced the incidence of relapse. And the benefit of blinatumomab appeared more prominent in patients with good MRD response prior to blinatumomab. So the question becomes, should we be incorporating novel agents in the treatment of MRD negative disease? Can we actually improve the outcomes of these patients? Now, why do we ask this question? Because MRD negative doesn't mean disease-free. MRD negativity is the target endpoint of frontline therapy. We now think we've shown that those who are MRD negative do better than those who are MRD positive. However, MRD negative patients still have a risk of relapse. And as we showed earlier, allogeneic transplant is often not justifiable in patients with ALL, and particularly in those who are MRD negative, given the high risk of treatment-related mortality. So ECOG-ACRIN E1910 was a randomized trial that asked about the role of blinatumomab in upfront therapy. The prior studies that I showed you all were looking at control populations, historical control populations. This was the first randomized trial. So patients were treated with standard combination chemotherapy using a BFM-like regimen. It was like UCAL12. The difference was that we used pegylated asparaginase instead of E. coli asparaginase in patients up to the age of 55 in induction therapy. We added Rituxan for those patients who were CD20 positive. And we extended induction therapy in this patient population. We took patients who were newly diagnosed between the ages of 30 and 70, who had an ECOG performance status of 3 or better. They got induction therapy, and if they were in complete remission, they went on to chemotherapy intensification using high-dose methotrexate and intrathecal methotrexate. And then they were assessed for MRD. And when the study was first written, blinatumomab was not approved for MRD-positive disease. So all patients at that point were stratified by MRD status and were randomized to either yes or no blinatumomab. They all got chemotherapy consolidation, but those who were on the blinatumomab arm got 2 cycles of blinatumomab prior to 3 cycles of consolidation, and then they got 1 more cycle of blinatumomab, the 4th cycle of consolidation, and a 4th cycle of blinatumomab. Those who were on the control arm got 4 cycles of chemotherapy consolidation. So it was 4 chemotherapies or 4 chemotherapies plus 4 blinatumomabs. The blinatumomab was given as a continuous infusion for 28 days with a 2-week break in between. And after that, all patients received maintenance therapy, and all patients completed therapy 2.5 years after chemotherapy intensification. So even though the patients on the blinatumomab arm had a longer period of consolidation, everybody stopped therapy at the same point because maintenance was determined Timing was determined by when they got intensification therapy, not by their timing of consolidation. This is looking at outcomes in the MRD positive patients. As I mentioned, this study was originally started when blinatumomab was not approved for MRD positive disease. So we had groups that were randomized. We had patients who were randomized to not get blinatumomab, and then patients who were randomized to get blinatumomab. About halfway through the study, blinatumomab was approved for MRD positive disease. So all MRD positive disease patients at that point received blinatumomab. So there were more patients in the blinatumomab arm than there were in the chemotherapy arm. But with a median follow-up of close to 4 years, the median overall survival in MRD positive patients was not reached in the blinatumomab arm, while it was 22 months in the control arm. This is looking at outcomes in the MRD negative patients. So these are patients who are MRD negative after induction therapy and intensification therapy. Looking at survival if you get blinatumomab with chemotherapy or only get chemotherapy. And as you can see here, there was a significant improvement in overall survival in those patients who received blinatumomab and were MRD negative compared to those patients who did not receive blinatumomab, and it's not subtle. And the same is true for relapse-free survival. So the major difference was because of relapse. Again, with blinatumomab and chemotherapy, overall survival, median overall survival not reached compared to 6 years in patients with chemotherapy alone. So they do significantly better than those with MRD positive disease, but we can make that even better. And I think there were 112 patients in each arm. We had 17 extra lives saved in the arm that got blinatumomab. And it was true for patients under the age of 55, as well as those over the age of 55, but it really shows in this patient population because we had enough patients to look at. We did not have as many patients in the over age 55. The difference is not as significant, but there is still a difference in all age groups. And we looked at patients, we called MRD negative for purposes of the study of less than 0.01% by flow cytometry. We looked at those who were between 0 and 0.1% and those who really had undetectable MRD. And again, there's a difference regardless of how you call it MRD, whether you call it greater than 0 and less than 0.01, or whether they had truly undetectable MRD. So there's really no patient population that appears to not benefit by the addition of blinatumomab for their MRD negative disease. So the conclusions of E1910 was that survival benefit was confirmed in patients with MRD positive disease who received blinatumomab in first remission. Relapse-free survival and overall survival benefit was demonstrated for patients who were MRD negative using a cutoff of 0.01 after intensification and received blinatumomab as well as consolidation chemotherapy. It seems as though the clearest overall survival benefit was for patients under age 55, but even those over age 55 had a benefit, even if it was to a lesser degree. And patients with undetectable MRD also had improved survival with blinatumomab. So in conclusion, MRD is an important prognostic indicator in ALL. MRD techniques and timing lead to different outcomes and interpretations. Very early MRD assessment around day 14. Almost all samples are positive using conventional MRD methods, but even that is predictive for outcome. Later MRD assessments, you need robust techniques, specificity, and speed to be able to use it for your assessments in your patients. We can use it to determine if treatment needs to be intensified, and perhaps we can use it to determine if treatment can be de-intensified or de-escalated in those who are MRD negative. For post-remission MRD monitoring, sensitivity really matters. There are new MRD detection methods, next-generation high-throughput sequencing to increase sensitivity. Combining those with molecular and genetic features further refines the prognostic ability and provides interesting insights into disease kinetics. Novel agents really allow us to intervene earlier with less toxicity and more effectively. What I didn't show was that about 400 patients were placed on the E1910 trial, but only 224 made it to randomization. So we still do have work to do. There are some patients with high-risk genotypes who did not remain in remission long enough to get these novel agents. So should we be moving them even earlier in the treatment of disease to really give this benefit to more patients? Blinatumomab has been shown in a randomized trial to improve survival in MRD negative patients. This establishes a new standard of care. But there are more opportunities and ongoing and proposed studies. In the current AYA trial that's going on in adolescent and young adults, we're incorporating inotuzumab early on to see if perhaps we can get more of those patients into that MRD negative status and into complete remission to then benefit from the blinatumomab. Can we use chemotherapy-free regimens in older adults? There are some studies using combinations of inotuzumab and blinatumomab, or very dose-reduced hyper-CVAD and then adding inotuzumab and blinatumomab. We're using MRD-directed risk stratification, incorporating novel agents. And there is a combined study by many of the European countries that's really looking at risk stratification and at the end of induction, risk stratifying by disease features in MRD, and looking at groups that can be intensified versus looking at groups that can be de-intensified based on that information. And some newer studies that are ongoing, there's the Golden Gate study, which is looking at subcutaneous blinatumomab with low-intensity chemotherapy versus standard of care for adults with newly diagnosed Ph-negative BALL to make this an easier regimen or easier agents to give. And I'll stop there. Thank you.
Thank you very much, Professor Lugo, for a very enlightening talk. I've got a number of questions here, so perhaps I'll ask Professor Lugo to address these questions before I open the talk to discussion to the floor. So I've received a number of questions here. I think I'll group them together. The first question is also a question I'd like to ask, and that is the difference between MRD measurement by molecular genetics, so NGS, and you've shown, in fact, in certain studies that NGS together with testing for fusion transcripts appear to be better than using one method on its own, and that NGS may be more prognostic as opposed to measuring fusion products. So what are your thoughts on these techniques? Are these due to differences in biology? Are these due to differences in sensitivity?
So I think it's a combination. So fusion products are really only limited to really a few diseases, right? We have BCR-ABL
Right,
and we
yes.
have K2MT2A rearranged are really the only fusion products that we have to look at. NGS goes down to 10 to the minus 6. And so I think that there is something about sensitivity. In the case of BCR-ABL, it seems that NGS is more prognostic. In the case of MLL or KMT2A rearranged, I think it is a difference in biology in the sense that you really have to get rid of both your NGS signal as well as your KMT2A rearrangement. And so I do think it's important to look at the disease type and to look at what the MRD testing is. The problem with NGS is you need to have a pretreatment sample to be able to use that. And so it's important to do that at the beginning, or else you won't be able to use NGS to follow your patients.
Right, thank you. Now, the next set of questions relate to the E1910 study. So basically, there are three questions asked. The first one is the use of flow as a measurement of MRD. Would you think that using more sensitive techniques might be more helpful? Number two is the number of cycles of blinatumomab. You've used 4, I think. Is there a reason for selecting that? Do you think that fewer cycles would do? And number 3 is that were there any patients in this study who received fewer cycles because of various problems? And if there were patients like that, what was the outcome of these patients as compared to patients who received the 4 cycles of blinatumomab?
Those are some very good questions. I think the choice of 4 cycles was somewhat random initially. The original trials that were done on relapse and refractory disease used 4 cycles, and so that was the reason we incorporated 4 cycles into the study. There were 112 patients on each arm, compared blinatumomab to chemotherapy. 59% of those on the blinatumomab arm received all 4 cycles of chemotherapy. The others received 1, 2, or 3. 2 cycles was the highest of those who did not receive 4. So I think 26% of patients received only 2 cycles. And I'm actually presenting at ASH this year that there is a significant difference in outcome in those who received 2 versus those who received 4. When you look at those who received 1 to 2 cycles, their outcome was not significantly different from those who received no cycles on the control arm. And there was a significant improvement in survival in those who received 4 cycles compared to those who received 2. Also, it did not seem to matter whether or not patients went to transplant. So transplant, although many of the patients who received 2 cycles went on to transplant, and that was the reason they received 2, the difference was just as significant in those who did not go to transplant. even in those who did go to transplant. So 4 cycles was better than 2, regardless of whether or not the patient went on to transplant. So at this point, and the numbers are really too small to say a lot about it, but there's no data right now showing that fewer than 4 cycles is good enough.
Right. Next set of questions would be the relevance of MRD in the era of immunotherapy. There are a number of questions asked, and I presume immunotherapy here refers to CAR T, if I am not mistaken. So what is the importance of MRD in this era of CAR T cells?
So let me go back to your first question. I just realized I never asked your question about flow. So flow was chosen because in the US, flow has been the standard of care of the pediatric population, which is where we've done most of our learning in ALL. Flow is a good method, and there are 2 issues with it. Are number 1, as I mentioned before, it's not as sensitive as NGS. And number 2, it's a very steep learning curve. Flow is very operator dependent. And so if it's not done by somebody who's very experienced, it really is not a reliable method of MRD assessment. So it may not be the best method for using everywhere and by everybody if you really can't train the people who are doing it. We had it done in one laboratory by somebody who was trained by the one laboratory that does it for the Children's Oncology Group. I'm not sure that that's realistic to really be able to use flow. So I think that is the major problem with flow cytometry. As I mentioned earlier, the major benefit if you're using different from normal is that you don't need to have a baseline sample to be able to do flow cytometry. In the US, NGS is now the only FDA-approved method of MRD for ALL. So I do think that that is going to become the way we will be looking. We are planning to reevaluate all the E19 send samples with NGS to see the outcome of blinatumomab by NGS MRD, but we have not yet done that analysis. In terms of your question about CAR T and such, I think the same is true, regardless of the therapy that is used, that MRD is predictive. MRD, both at the time of disease relapse and MRD can be followed for recurrence, is predictive of early relapse. And so I think at this point, regardless of the method and regardless of immunotherapy. Now, I think what may be different, as I mentioned earlier, is MRD may redefine prognostic subgroups. So whereas we used to use clinical and cytogenetic and molecular assays to define prognosis, that may no longer be relevant in the age of immunotherapy. It could be that as we add immunotherapy, we will now redefine what good prognostic and poor prognostic ALL is based on the response, the MRD response to that immunotherapy.
Right. 2 more questions, more clinical. The first one is in older individuals, the use of asparaginase or PEG asparaginase. What is your experience?
It's a challenge. L-asparaginase is difficult to use. So when we did our AYA trial, and I would say old at that point was over age 21, when you compare patients in the AYA study, C10403, who got PEG asparaginase, to the standard pediatric regimen, we saw a few different things. We actually saw more patients who were not able to tolerate, so we had to add steroid premedication for PEG asparaginase, even they don't do that in the children. We saw a significant increase in liver toxicity. We're actually now doing some studies with some prophylactic agents to try and decrease liver toxicity. And there was a significant increase in thromboses in the adult population. So I'm talking about the adolescent and young adults. So these are patients between the ages of 15 and 40. Those who were between the ages, I would say, of 20 and 40 had a much higher risk of DVTs and we had some fatal clots in this patient population compared to the pediatric population. So we now actually routinely anticoagulate all of our patients who get asparaginase until they're done with all of their asparaginase, even in consolidation, because of the higher risk of, and then we also supplement them when we can with AT3 because the anticoagulation is not useful if they don't have antithrombin at the time after they get the asparaginase. And so that is a challenge. In ECOG 1910, we only gave PEG asparaginase to the patient population that was under age 55 in induction therapy, but we did add it to post-induction therapy for the older population. We used it in consolidation. We used it at a lower dose. We've tended to go with lower doses in adults over the years because of the increased toxicity. We're starting to see if we can assess whether or not we're getting the same benefit. We have a few studies that have looked at levels, and it looks like adults really achieve therapeutic levels at much lower doses. So I think we can hopefully get to a point where we can get to lower doses, but not get the toxicity. There's a publication that actually came out in the last month by a Mexican group looking at the use of asparaginase, E. coli asparaginase rather than peg asparaginase at lower doses and fewer doses than what we traditionally use, and being able to use it and manage the toxicity. And so I think we all can learn from that, and that we don't need to use these higher doses, but I do think it's an effective agent.
Right. One more question on pH like ALL.
Yes.
How is that different from treating others?
So pH like ALL is an ALL that uses the same pathway as the Philadelphia chromosome. Unfortunately, so in pediatrics, many of those patients use pathways that are tyrosine kinase sensitive. And so in that patient population, the pediatricians actually use dasatinib or even ruxolitinib in many of their pH-like patients. Unfortunately, in adults, the majority of pH-like patients do not have disease that's targetable. And so we don't really have agents that we can add to their therapy. I think as we do these studies, and we don't have that information yet, I think what we will find is that the pH-like patients are more likely to be MRD positive after induction and need intervention with another agent. Whether that should be blinatumomab right after induction, or whether that should be one of the other agents, or whether we should be incorporating CAR T cells into that patient population's initial therapy. I think that is what the Altogether study will be doing in Europe. I don't know, but I do think that we will be learning that defines a biology that is not sensitive to our traditional chemotherapy alone.
Right. I think we do have time for a very short question. And the question is, MRD positive patients in this era of immunotherapy, given all the new agents and novel agents, and if you can render these people MRD negative, do you think there is still a role of allogeneic transplantation?
I think that's a great question. And I think there is some data that suggests that those who are MRD positive, who achieve MRD negativity, do potentially as well with and without a transplant. There are some attempts at randomizing those patients. I don't know that we'll know the answer, but I do think that if you can achieve MRD negativity with very sensitive MRD, there may no longer be a role for transplant in that population.
Right. Thank you very much. Thank you.
Okay, the next session will be the discussion on the acute lymphoblastic leukemia from the Asia Pacific Leukemia Consortium survey. So we have one presenter and two panel discussion. Please welcome all of them to the stage. So the presenter will Professor Ashley Ng from the Peter MacCallum Cancer Center, Australia. And we also have two panel discussion. Professor Jin Ji from Zhejiang University, China. And the last panel discussion is Professor Lim Su Min from Sultana Amina Hospital, Malaysia. Everyone, please welcome all of them.
Thank you very much for the invitation to present at the symposium today. And I also grand welcome to all my panelists this morning. What a wonderful presentation we had. Professor Lugo is fantastic, and what will probably will redefine how we approach treatment of this disease. So if I bring this discussion, perhaps reframe it following that presentation in terms of we wanted to understand how we treated acute lymphoblastic leukemia in the Asia-Pacific region. And this was, interestingly, not too much literature present. And in my role as a clinical hematologist, but I'm also a clinical informatics lead at the Peter Mac Health Service Research Department, it was something of interest to us and also interest to the Australasian Leukemia and Lymphoma Group to understand how we treat the differences in how we approach this. So this came out from a survey that was developed from myself and Dr. Kevin Koh and Dr. Lao Zitang, as well as Lin, to put to a member sites, looking at the various things that we do in terms of our treatment approach approaches for ALL. The diagnostic approach, assays used, the high-risk disease stratifications, what frontline treatment protocols are being undertaken at a number of different sites, the chemotherapies, immunotherapies, targeted therapies, and cellular therapies, and types of approaches being used for relapsed and refractory disease, and whether or not the group as a whole thought guidelines for this approach for this disease for all these domains was going to be desirable. So the survey had respondent countries from 6 countries ranked only in alphabetical order, from Australia, China, Hong Kong, Malaysia, Singapore, and Thailand. And these are the hospitals that from responded. I'll let you read that there. I won't go through all of them, but thank you to all the respondents who are listed in the far right column for their time and effort. As people who have done the survey know, this was actually quite a detailed survey and would have taken quite a bit of time to get all their information in. And I think, Lynn, the survey actually is still open for the points, I believe. So if any further hospitals would like to continue to contribute to get a feel for how we are treating ALL in the APAC region, please feel free to undertake this with your hospitals or some of your junior medical staff as well. So the results of the survey are very interesting, and it showed actually quite some insights, which I'll get to at the end. And here we're looking really at the diagnostic approach. And it was actually quite fairly standard in terms of basic phenotyping, with looking at high-risk disease stratification features. And there was consistency in the approach from all the hospitals in terms of the use of white cell count as a prognostic factor. The karyotype in FISH for BCR-ABL or KMT2A rearrangement. And there's actually quite a significant number from the respondents of hospitals undertaking next-generation sequencing and other measures. MRD was also measured, flow cytometry being the most predominant way of measuring it, but also use of cytogenetics and next-generation sequencing with MRD thresholds which have been defined at 10 to the minus 4 to 10 minus 5 in terms of potentially making therapeutic decisions. And the MRD testing schedule was quite variable. Sometimes post-induction, post-consolidation, so one every 3 months, at 2 years, or pre and post-allogeneic transplant. And as you saw from the previous presentation, that the risk of MRD is important, but can also be thought of potentially, depending on the time point, a continuous variable with variation across different time points to predicting the risk of disease relapse. An interesting question that we often ask, especially prior to maintenance therapy, is potential looking at pharmacogenomic approaches to identify patients who may be at risk of some of the agents that we are using for significant cytopenias. And the variability of pharmacogenomic testing was actually quite apparent across the different sites. The most commonly done one was not to do it, followed by TMPT and NUD15, which was more frequently done than MTHFR mutation testing. All of the sites, or most of the sites, had multidisciplinary team meetings for individual case discussions to discuss cases, follow them through, and make decisions about their treatment. And all sites had a protocol-directed approach. Most of them were site-specific, but some of the sites also used other resources such as NCCN or the EBQ. So I'll quickly go through these slides because there's quite a lot of variation between practices. Here we're looking at the protocol for chemotherapy backbone and chemotherapy, and as well as use of radiation therapy. So the number of different pediatric-inspired protocols were quite varied across the different countries, but most of the sites actually would have implemented a pediatric-inspired protocol. For adults greater than over 40-50, hyper-CVAD was the preferred regimen used. Modified GMAL was used in a small proportion of hospitals. And you can see the issues or the variation for older patients and the unfit patients. And as we know, we'll talk in the panel discussion, this is a cohort of need. T and B, differentiation between backbone chemotherapy was generally the same. Some sites had a different protocol for T-cell ALL, And the interesting variation in terms of radiation therapy was seen as prophylaxis. That means in the absence of disease can be seen there. Radiotherapy was fairly uncommon upfront in those patients, but radiotherapy was common in patients who had disease identified in terms of scheduling at some time during their treatment course. As we were speaking about before, just the last question, with asparaginase. All sites were familiar with the use of asparaginase. L-asparaginase was more commonly used across the Asia-Pacific region than PEG asparaginase. Oftentimes it was in the context of using it in the pediatric inspired protocol. And in some patient cohorts, it was introduced if a patient had failed to achieve CR, although that's not commonly done. Asparaginase pre-medication was variable. More or less it was 50-50 across all the different sites. Routine asparaginase monitoring, however, was commonly done, including antithrombin replacement, monitoring liver function tests, monitoring for diabetes and hyperlipidemia. In terms of targeted therapies, there's a variation in use for BCR-ABL from the original imatinib to a number of second and third line generation TKIs. And immunotherapy was actually quite frequently used, with rituximab as well as blinatumomab more commonly used than inotuzumab. And it was mentioned in terms of survey response, one of the issues in terms of making that decision was cost. And that's something that we need to think about in terms of how we fund these medications in patient cohorts in different countries. Clinically, in terms of, you can see in general, white cell count, CNS disease, failure post-CR1 were high risk factors. MRD detection was thought to be a high risk factor, either post-induction or post-consolidation. Those are the genetic subtypes you can see there. And when we refer a patient for allogeneic transplant, referral at the time of CR1 was more common than CR2. It was thought for the referral to allo, the MRD elimination prior to allogeneic transplant, again, more commonly done than not, but cost was also mentioned as an issue for the patient population, either using immunotherapy or targeted therapies, such as with third generation like ponatinib. Maintenance therapy was done by all sites, 2 to 3 years in general POMP, but also some variation depending on sites from Malaysia, for example. Plus, of course, a TKI if they were Philadelphia positive. And long-term follow-up clinics were done in the majority of hospitals. There was a variation quite significantly in refractory relapse patients, different types of chemotherapy, including moving into newer agents of use for acute myeloid leukemia, such as Flavida or Flag-Ida, generally adding asparaginase to hyper-CVAD protocols, for example, topoisomerase cyclophosphamide, and for TAL or neuralabine. Immunotherapy, as obviously discussed before, used now, and other types of therapy have been considered, such as DARA, bortezomib, and venetoclax. And cellular therapy is interestingly, with the emergence of CAR T as an option in our patients, it was actually available and used in the majority of sites. Most sites thought that clinical trials, or actually undertook clinical trials, which actually is as a flag for a significant opportunity for hospitals in the Asia-Pacific region to think about that in terms of consolidated trials in this region. Most saw a need or benefit consensus guidelines. In fact, all of them actually saw also a need for molecular tumor board interpretation. And NGS in diagnostic workup, not all sites had availability of that technology platform, or those technology platforms. Currently, most weren't using that because of the expense and also the expertise in interpreting, processing the data, and also understanding the variants, and also the expertise in interpreting the data. So in summary, 12 hospitals, 5 countries. The diagnostic approach was actually fairly aligned, especially with regards to high-risk disease stratification. And that's potentially not so surprising given the literature that exists in terms of identifying those cohorts. There was a variation in the frontline protocol given, which can be expected, but the actual core principles of the diagnosis and treatment are fairly aligned across 5 different countries, which I actually found that quite impressive. And all the sites thought trials and guidelines were actually very desirable. So just to step back from the Australasian Leukemia and Lymphoma group, the ALL working group, we have developed some guidelines for our patients recently that I led. And obviously this is a changing environment, as we know, as we will see the results of trials, as Professor Luca mentioned, and presented as a key principal investigator, that will potentially change the landscape of how we treat ALL over the next 12 to 18 months. Interestingly, in terms of initiatives that could be open to the APAC region and the APLC, thoughts about molecular tumour boards, and Matthew Greenwood from Australia is leading the idea of a molecular tumour board in Australia. Think also about the economic impact of whole genome sequencing and whole transcriptome sequencing versus our routine molecular testing. And that's going to be quite important, and thought how you approach this in each of your countries. This has been undertaken, for example, in our centre by Martin Vu, who's a PhD student, looking at the impact on the Australian costs for implementing whole genome sequencing. I won't present the results here, but he will publish this soon. But there's also significant opportunities in this region for guideline development, incorporating emergent trial data, looking at opportunities for clinical trial development across the different countries, knowing that the approaches, the agents used, as well as the diagnostic approaches used, are actually quite aligned in 5 different countries. There's also a great opportunity, as we'll come to tomorrow, to talk about development of a real-world registry to look at collecting information and data about how we treat ALL patients in this region. Thank you.
Thank you very much, Professor Ung, for your kind presentation. And I think it's very interesting for the survey that we see different treatment all over Asia Pacific region. Yes. I think the next is the panel discussion. If you have any question, can you have the QR code here? You can scan and send the question to our speaker and the panel discussion, please. Maybe I should begin with the first question. I think right now we use the pediatric inspired regimen for the acute lymphoblastic leukemia for the adult, young adult and adolescent. But it's improved survival, but it can come with toxicity. What is your experience about this? And do you think what is the upper limit of the age to use the pediatric inspired regimen? Yes, maybe the panel could share. And you can scan the question here. Right now, there's no question.
Yeah, I'm very honored to be here to take part in this APLC meeting. In our hospital, we always use we have de novo AL patient, adult patient, about 100 per year. We generally use the DLBCL for de novo patient, and we stratified this patient by NCCN to stratify if patient the higher risk. We always after chemotherapy and the patient got the CR, we will use the bone marrow transplantation for this patient, and if patient got the relapse, or we will, if the patient can afford the blink to number, and we will use this drug to treat them. And after the patient got the CR, and we will give them bone marrow transplantation. Sometimes, if the patient is older patient, we will anti-CD22, antibody, ADC antibody, and we will continue to detect the MRD. This is our hospital situation. Yeah.
Thank you.
Good morning. If I can just add my experience, we used to use hyperCVAD until about three to 4 years ago. We adopted the MASPOR protocol, which is developed by Prof. Alan Yeo in NUS Singapore. Initially, we encountered a lot of morbidity, especially liver toxicity from the high dose asparaginase. And we have learned from the Singapore team that actually adult patient can use a much lower dose of LSPAR, and they do the the serum asparaginase activity, and it proved that the level still able to suppress the um, so we have cut down the dose, but there is a learning curve. And we actually lost quite a number of patients initially, but we are starting to see a survival trend now from using the pediatric Inspire protocol. So I'm actually very keen to do that. I did a presentation a few months ago in the Malaysian meeting, but I can see quite a number of adult hematologists are still a bit worried of switching to use a pediatric Inspire protocol. The problem that we are facing now is the Kiowa Kirin is phasing out the LSPA, and we are now have to switch to PET LSPA. And I heard from Prof. Luca thought, so I'm going to be very cautious of using the PET LSPA. But we routinely add in the Clexane as a prophylaxis, and we don't see much of thrombosis, thankfully. Thank you.
Professor Ng, please.
I'm a doctor, so I'm not quite a professor yet. Thank you very much, though. My feeling, we've been using the pediatric inspired protocol, initially the COG 0232 at our institution, but recently switched to a BFM-based backbone because of the ALLG AYA trials. Again, I agree with all the speakers and Professor Luger as well that these are more complicated protocols requiring a centre who has experienced both nursing staff and medical doctors as well as outpatient management to be need to be on top of everything in terms of monitoring. We do pre-medicate with asparaginase. We had to choose pig asparaginase because of the costs, because they stopped making L-asparaginase in our region. From the company stopped making it, and the costs were too prohibitive. So we've all adopted the pig asparaginase approach for at least 4 years. Absolutely, monitoring their antithrombin levels, giving Clexane prophylaxis, making sure that we monitor the liver function testing glucose. Yeah, as people know in these centres, that this is almost a full-time job. So very important that we have experience in this. And I look from the survey, it shows that most centres actually do have experience in this, which is pleasing. I'd also potentially like to ask Professor Lim about the doses of peg asparaginase that you've been using.
The one that is proposed by Prof. Alan Yu is about 1,500 IU per meter square. And that's for the induction course where there will be 2 doses given. The subsequent during the consolidation will be 2,005, but that was only 1 dose per cycle. And there's a max of 3,750 IU per dosing.
And do you routinely undertake monitoring of asparaginase levels, or asparaginase activity, asparaginase activity?
This test is actually only available in NUH. So we have done for a few patients, but I have to say it's not easy. It requires a lot of arrangement to make sure the sample is reached there in time. We tend to do that when we switch to PET LSPAR, we're definitely going to do that for the first few patients to make sure that we are giving an adequate suppression. Our upper age is actually, we push up to about 45, but I have to say between 40 to 45 is quite challenging. So I guess below 40 is quite all right to use the pediatric regimen.
Could I also potentially ask your approach in patients who are planned to undergo an allogeneic transplant? And do you make any significant dose modifications or remission of asparaginase prior to that, potentially because of liver toxicity?
So far, not to my knowledge. The field we actually have not subjected to that many patients to transplant for ALL because we see that the morbidity is quite high. So we actually will try to avoid it as much as possible. Versus our AML patient, we see a better outcome. So I can't really say that. Not much of experience.
Shinji, you want to share it?
In our hospital, if patient have donor for adult patient, if patient have a donor, even the MRD negative, we always give the bone marrow transplantation. But sometimes the MRD is positive. We will, if patient can afford the Blincyto, antibody, we will use to clean the MRD, then give them the bone marrow transplantation. About 30% patient will receive the bone marrow transplantation for adult ALL.
Could I ask Professor Jin then? I know that some of the Chinese experience has been recently published for ALL in leukemia lymphoma, and the use of CAR T cells, and from what you discussed, is quite more common than we have used. And your thoughts about if blinatumomab was more available, from cost wasn't prohibitive, your thoughts about blinatumomab versus CAR T in your therapeutic approach?
Yeah, but in China now, CAR T is always for clinical trial, not available by commercial. So if patient can afford the Blincyto, we will give them Blincyto. If patient cannot afford, we will search for CAR T therapy. But I think in near, maybe next year or the next month, the CAR T anti-19 CAR T will be available in China. Yeah, that was invented by Professor Wang. Yeah.
I'd like to ask the panel here this question. Here we're discussing the use of very complicated regimens with a lot of toxicities, and a lot of the people in the audience work in academic centers, and pretty much in academic centers you can do whatever you want because the medical staff, nursing staff are all experienced people. But if you're talking about not every patient with ALL is treated in academic centers. So if you look at smaller centers and smaller hospitals, do you think that such complicated regimens are practical or even practicable?
Okay, that's a very important question. I am on the ASH guideline panel for AYA at the moment, and this was raised as an issue in terms of an academic centre versus other centres, and the approach, the use, for example, hyper-CVAD versus an AYA regimen. And it's something that needs to be considered, I think, from a hospital-specific or region-specific thoughts, because most of our ALLs are treated in Australia, if not all of them, at academic centres specialised. We get the referrals for all acute leukemias at quaternary hospitals, and it's not something that I've been familiar with, shall I say, in terms of having a difference in terms of approach, because our regional centres would refer them in, and sometimes our patients from a regional area would come in from 4 hours away and sometimes interstate to be treated by us, rather than being treated at that regional centre.
Sorry, Adisa. Let me just interrupt for a while. I don't interrupt this short while for the very interesting discussion. Just to remind the panel that we only have limited space on stage for the panelists, but there are many other countries and very eminent experts, like for example Taiwan, Korea colleagues as well, in the audience. So maybe you can have an engagement with the whole session and the floor, and then the floor, please feel free to chime in, not just a dialogue here, but with what Prof. Luger, she actually a very fantastic lecture. I don't know how she covered that. So much scope in such land, and very, very nicely done. And a lot of, obviously, different practices, different areas for ALL, very complicated. So BCL label, VDF positive, so many things. So maybe engage the panel and that maybe hear from our Korean colleague or something, Taiwanese as well. Okay, so just feel free to raise your hand. Yeah.
So, any comments from the floor?
Yes, please.
Professor Huang?
Yeah, 建祥.
due to the survey, also some patients get the chemo transplant, but also from the talk from the Professor Luca, also, and at present, so auto transplant won't be used anymore at present. But for this era, we have immunotherapy, eliminate MRD. Maybe we can reevaluate a role of auto transplant in this time. What do you think? What is your opinion, Professor Luna, also panel? Auto transplant.
We don't undertake autografts for ALL therapy, but
I think you raise a good question about whether there's a role for auto transplant. I guess the same question is whether these patients need the auto transplant again. So I don't think, I think we've learned that MRD negativity is not perfect. But once we have how do we then select those patients that need to enhance their therapy by getting further therapy with an auto transplant? And I don't think I think that's reasonable in those patients who are MRD negative. I would not consider it unless they were MRD negative and received immunotherapy afterwards to enhance their likelihood of staying in remission. But that's a very small patient population that then is at risk. And is it worth giving them the risk of the auto transplant at that point?
Can I just ask Selena another question? Selena, behind you, with the E1910 study, obviously really impressive outcome for the investigational arm over no blin. In the control arm, I just wondered how many patients received blin at salvage, and did that equalise things, or do you still think there's a clear benefit for giving blin upfront rather than at the time of salvage?
So patients were allowed to get blinatumomab at salvage. They were not restricted, yet there was still a significant overall survival benefit for those who did not receive. And I suspect almost all patients who relapsed after chemotherapy received blinatumomab salvage. And so there was significant improvement if you got it up front as opposed to waiting until they relapsed. I think the question really is, should we be giving it after induction as opposed to waiting until after intensification? Again, because half of our patients did not make it to the randomization. Clearly, we have work to do there.
Yeah, thanks, Prof. Luger. My question actually pertains to the 1912 as well. There's not much data on toxicities, and I know that your ministry is in progress. And there's also some data that the benefit is actually seen in a younger group below 55. And is that because of the toxicity for the older group and the number of blin doses they were able to get? Because all these, we don't see that much in publication yet.
Fortunately, in patients who are MRD negative, there was very, very little toxicity. So the group that got blinatumomab versus those who got chemotherapy alone did not really have any excess blinatumomab-related toxicity. I would say that we saw some cytopenias, even in patients who were MRD negative, that required decreasing in dosing. Very few patients who did not get all 4 cycles did not get it because of toxicity. It was almost all because they went to transplant. The few patients who went to transplant, there were maybe 1 or 2 patients who stopped after 2 to 3 cycles who did so because of toxicity. So almost all patients were able to get 4. I think the problem with the older patients is just we had fewer older patients on the trial. And so we were not able to show a statistically significant benefit. And if you look at the hazard ratio for the older patient was lower than it was for the younger patient. So there was a benefit, but it was not as significant in the older patient. Now, these were all patients that got randomized. There was a higher risk of high-risk genotype in the older patient. And if you look at, we had a combined risk, so we looked at risk based on cytogenetics and molecular risk at presentation, and that still held to be prognostic even with the blinatumomab. And more of the older patients had poor risk disease. And so again, I think that even blinatumomab did not overcome that completely in this patient population. And so maybe we need more than that. Again, maybe we need to give it earlier. Maybe we need to add additional agents. And again, the older patient population, we hesitate to take to transplant. and they are MRD negative. I don't know if the older patients were more likely to be in the MRD between 0.1 and 0. I don't have that broken down yet, but it did seem to benefit all of them.
Maybe since our chairman asked us to engage the audience, Dr. Go from Taiwan, you have any additional comments on this?
Thanks for the chairman's annotation. Okay, I think in Taiwan currently there are several things that need to be addressed. The first is that actually blinatumomab is reimbursed only in the second line treatment for the acute lymphoblastic leukemia. And for MRD treatment, I think it may be started in the next year. So currently we have only chemotherapy used for clear the minimal residual disease. So currently, I think the transplantation is still something that very important for those who has a positive MRD in early stage. And another thing is that the so-called pediatric inspired or the protocols usage. I think we are now currently engaged some programs who are trying to engage all patients below 45 years old to have a pediatric inspired treatment. And also for the patients with fit condition in 45 to 55 years old, I think we are also trying to engage the pediatric inspired protocol. So currently, I think another thing is that actually maybe in the next year, the Taiwan government may reimburse the NGS study for the ALL, but only one time for lifelong. So maybe it will help us to improve the risk stratification program for the ALL, but to use the NGS as a minimal residual disease identification, I think it will quite a long way. So we are currently still use the multicolor flow cytometry for minimal residual disease detection.
Perhaps I can ask you this question. How do you convince the government that blinatumomab is an expensive agent? I suppose if you calculate the cost of using a number of courses of blinatumomab versus, let's say, doing an allotransplantation, maybe allotransplantation is less expensive. Is that your experience with the economics in Taiwan?
I think the first is that we do some cost-effective analysis, and especially in Taiwan, we have a so-called HTA agent to conduct the whole analysis. So I think it is not actually a problem to convince the government because we have enough data and enough cost-effective analysis data. But the issue is under the negotiation between the manufacturers and the government. And another issue in Taiwan about the health insurance is that we have a global budget. So if we reimburse this part, then we will try to sacrifice some other things in the whole registration system. So the government maybe need a whole plan for that. But I think it will actually, from the way of a cost-effective analysis, blinatumomab usage in clearing minimal residual disease actually is still cost-effective. So I don't think there will be a problem to convince the government.
Thank you.
Could I say something?
Yeah.
Just want to echo what Professor Kwang has mentioned. The current treatment regimen for ALL is very complicated and very difficult to execute in parochial hospital. Now, there are some talks from MD Anderson. The AL treatment now can be simplified. Suddenly the Blin plus Pona seems to give excellent results. So I just want to ask Dr. Selena, if you look at the crystal ball, would you think that treatment of AL will be more simplified and perhaps easier, than the very, very complicated pediatric regimen and so forth?
Working. I think the use of immunotherapy will simplify it. If you look at some of the older populations, there are some studies now that have looked at inotuzumab, blinatumomab combinations for induction, just followed by pump maintenance. The mini hyper-CVAD and modified, we have a current study going on looking at mini hyper-CVAD with inotuzumab versus modified hyper-CVAD followed by blinatumomab for all patients who are MRD positive or negative at this point. I think we'll learn whether or not that actually allows us to have less complicated regimens. These agents are easier to tolerate once you are MRD negative, but not necessarily easier to tolerate when you have disease. You had a question about liver toxicity and transplant. And although we don't have to modify transplant for asparaginase, we definitely have to be concerned with inotuzumab. And we minimize the amount of inotuzumab in a patient who might be a transplant candidate. So we were fairly easy using that in our older patient population that was not transplant candidates. But once we start thinking about these agents in the younger patient population, and if they are potentially transplant candidates, we have to consider the risk of allotransplant in that population as well. And so easier on one end may lead to other problems on the other end.
Based on the survey, for a young patients, that means young adults say BLL patients, then in chemotherapy will be choose the inspired pediatric regimen. So my question is by the incorporation of immunotherapy and for the young adult patients, especially near age 40, and can this strategy can be changeable? That means incorporated the immunotherapy, the inspired regimen. This strategy can be changeable.
So are you asking whether or not you can incorporate immunotherapy into the AYA patient population, right, into the regimen, and how will that modify it? So that hasn't been done. So interestingly enough, the pediatric population has not incorporated any immunotherapy into their regimens, which is very interesting. So there are a couple of situations where they have, which somewhat answers that question. In the Down syndrome population, they have shown that there is a significant benefit to blinatumomab, and they can replace some of the chemotherapy. There's a pediatric COG study that looked at relapse disease, and instead of adding blinatumomab, they actually took out their delayed intensification cycle and replaced it with blinatumomab. And they showed an increased likelihood of going into remission in the arm that received blinatumomab rather than chemotherapy and consolidation. So I do think there are a lot of these questions that can be asked. Perhaps we do our standard induction therapy, but then replace some of our post-induction chemotherapy. Perhaps the study that we did could have been blinatumomab versus chemotherapy consolidation. Our post-induction chemotherapy is quite complicated. If we can do that, that will make things easier. I just don't think we have those answers yet.
Okay, thank you.
My question is for adults patients. We still use the inspired pediatric regimen for age lower 39. So for this population, we can change the regimen.
We are currently in the clinical trials group discussing what the next generation of trials should be. And I have to say we're somewhat split in our conversations about whether we're comfortable discarding chemotherapy completely and switching to an immunotherapy-based induction regimen, or whether we need to just try and slowly evolve to one that eliminates it during separate sections. But there are clearly people in our group who feel that we should take the jump and move to a chemotherapy-free regimen as our next induction, which I don't think we're ready for it yet.
I have to thank you very much. There is still some question, but I think with the limitation of time, we have to end this session. I would like to thank my chair and all the presenter and all the panel discussion and all the audience for the very interesting and fruitful question. I think we have 15-minute break, and maybe we can discuss during the break, and we will come back at the 10:40, yes, for the CLL session. And thank you very much for everyone. Thank you.